Dr. Sandeep Nayak. Dr. Sandeep Nayak is a professor and head of the Department for Minimal Access Surgery. He's also a Director of Surgical Oncology, Max and Fortis Hospitals, Bangalore. So he'll be talking about, can MIS replace the conventional approach in head and neck surgery? So yeah, please welcome Dr. Sandeep Nayak onto the stage. Yeah, you're.
Thank you and good afternoon. Yeah. So I have a task of talking about minimal access surgery and to discuss whether it can replace conventional open approach in the coming years. So as I looked at this topic, my thought was that, this is the list of things which I can think of, that is thyroid, neck dissection, parathyroid, the salivary glands, the parotid and the other salivary glands, thyroglossal cyst. In a way, TORS, that is, pharynx and the larynx do, belong to the neck as well. And if you look at CT scans and all that, base of skull also is a part of neck. But I will not be covering that, though I have a few slides on that. So my talk will be around the first few things that I have listed here. When it comes to the evidence, it's always a pendulum because it swings from one end to the other, wherein it is unsafe to being sometimes better. And it has happened in surgery several times that, we have had various research that has come and shown that, sometimes it is unsafe to being better in some extents. We have had a lot of history on that. But when it comes to head and neck and minimal access, there is very few research in the form of research that we can really look at. And what I could get was some meta-analysis that were done. So I thought, it's not a good idea to really look at the amount of evidence and rather go with what I practice and what I see, that is in my opinion and my work experience, which is very limited. So that's what I'm going to present. So what I would be telling you is more of an opinion and what you can see in the form of videos and pictures that I'm going to show. So the first thing that I'm going to talk about is thyroid. And when it comes to thyroid, why did minimally invasive surgery start? The whole idea was about avoiding a scar in front of the neck. That's how it started. And if you look at the history, it was 1997 when the first endoscopic thyroidectomy was performed. And in 2007 is when first robotic thyroidectomy was performed. Intention was avoiding a scar in front of the neck. And it is very important because most of the patients who come to us for thyroid surgery are quite young. They don't want to have a scar in front of the neck. Now, what are the different approaches when it comes to thyroidectomy? This is a good paper which you can look at it. In fact, robotic and endoscopic thyroid surgery evolution. This is published in 2020, I guess. And it's a very nice paper which really lists the entire gamut of surgeries that are available for thyroidectomy. So the transaxillary and the retroauricular approach are the two most commonly used approaches across the world when it comes to robotic. And when also the transoral or the retrolabial approach is one of the approaches which is used. What I have done was the modification of the Baba approach, which I used to practice over for years, and then I changed the same approach to modify it and started presenting it, doing it. So this is how do I play this in this mode? Yeah, so this is how we perform the creation of the space. I'll quickly run through this because we have limited time today. So this is the first port once this incision is made and we create the space. So 3 ports are placed and we create the space further to have more space for the surgery to be performed, 3rd and 4th spaces. This is the rabbit technique which I'm talking about. Once that is done, this is how the surgery looks, this is how the field looks. So this is similar to what you see when you do a open surgery. You have a typical surgeon's view of the field. These are the strap muscles, the midline. We have split the midline and going into the central compartment. This is the thyroid, middle thyroid vein. This is the tracheoesophageal groove where we go into the loose areolar tissue to dissect it out. Superior pedicle is taken. This is a very high speed video, but you can see the external branch of the superior laryngeal nerve over here. So once that is cut, the superior pedicle is dissected and taken care of, we go to the recurrent laryngeal nerve area. So as you can see, this is the recurrent laryngeal nerve here. This is the recurrent laryngeal. And the parathyroid gland is here. These are the 2 parathyroids. So you can see with indocyanine green, you can see the 2 parathyroids lighting up very well. They are the first structures to light up. So this is the recurrent, this is the Berry's ligament. So, what you can see here is the magnification that the robotic system provides. It's the 12x the camera magnification which is there, plus what happens is you can go very close to the organ, so that also adds to the magnification. This is the left side. I do it from the same side. So this is the recurrent nerve which is shown there. And you can see the upper parathyroid over there. Again, the superior pedicle. And taking down of the superior pedicle, we just need to do bipolar. For that, we don't need to really use any other ligation. That's the external branch of the superior laryngeal nerve. And that, so thyroglossal tract. So now, once that is, that specimen is removed through the axillary incision. Now, the advantage that we can see there is the magnification, and when we have to do a complete neck or central compartment dissection plus bilateral neck dissection, we can perform the entire surgery through same incisions, same port positions without changing anything. So that's one of the greatest advantages which I found. So when I look at the entire surgical or the advantage, this is one of the greatest advantages that I see when we have to do an extensive neck dissection. So the entire surgery or the largest incision that we place in these patients is this, about 2.5 centimeters. And this is the healed scar of these patients. So, these are, patients are quite happy with this. About 9, nobody has ever complained about any of these scars. Now this is before and after. So, is it all about scar? So that's what I started looking at when I looked at the, over time, how it was, coming out. When I completed about 150 cases. This is what I started asking myself. Let's look at what is it really looking like. And in fact, I took out the world literature, and I was seeing that, the permanent hypocalcemia rate was about 6.6%, when about approximately 4 to 6 or 3 to 6.6% is what I was getting across. And one of the reasons was the inability to identify parathyroid. I know experts like Dikrus sir or Dr. Pai, they do huge volumes and they can identify the parathyroid, but generally it is, what is said is, the color of parathyroid is like the color of, tongue of a jaundiced hummingbird. So it's quite a difficult thing to identify. So when, what we really need is a better vision and better differentiation. So this is one of the short videos I'll show you. So to identify, this is the left side. You can see the parathyroid gland, suspected parathyroid. I'm not getting the arrow over here. This works? Yeah. So this is the area of parathyroid. So we are given indocyanine green. This is the area. So once you change the light, that's the first structure to light up. You can see the clear structure to light up. Node will not light up like this. If at all, only a blood vessel can light up like that. So that's the advantage which we get. And see, it's completely dark space. Unlike open surgery, where you can't use indocyanine green, here you can use indocyanine green really well. So this is the recurrent nerve. I don't want to, I'll just run this because I'm not, yeah, it's here. See, towards the end, oh no, I should have shown you the vessel as well. Yeah, see this is the blood supply to the parathyroid gland as well, which is saved. So it is possible to identify the gland and preserve the blood supply with absolute clarity because it's possible to do it robotically. So this is what I spoke about. See, this is just an example to show that, with no magnification, this is the view, but with 12x magnification, you can clearly see a bird which is sitting there. So this is what we are targeting. Now, what is the extent to which we can go? Today we are performing 10 centimeter glands as well. But what is important is these cases which have intrathoracic extension. The problem with this type of cases is you need to do a thoracotomy in most of these cases. This is a 15 centimeter extension into thorax. Now, 10 centimeter extension, this part was in the neck. So we do a combination of robotic assisted thoracoscopic surgery plus rabbit to give a result with which we can, with no incision, almost no incision, we are able to complete the surgery. So now coming to the parathyroid gland adenomas, it's another interesting thing which I wanted to show you. See, we used to do a lot of these parathyroid adenomas referred by endocrinologists because we used to try to use small incisions. In fact, when we are less experienced, that's what we try to do. But the problem with that is anatomy is obscure. It's very difficult when you use small incisions. So what happens when you perform the endoscopically is you have a full view of the tracheoesophageal groove. This is omoid muscle. I'm entering the space between the two heads of sternomastoid. These are two heads of sternomastoid. This is left side. So this is the central compartment. I have lifted the strap muscle up. So this is the parathyroid gland. The adenoma, sorry. This is the lower parathyroid. This is the upper parathyroid, which is the adenoma. So as we dissect, the gland becomes clearer and we can identify the recurrent nerve. This is the recurrent nerve. This is the inferior thyroid artery. And this is the lower parathyroid. This is the upper. So this is the adenoma. So, the confusion as to which is the adenoma, have we hit the right target, is totally eliminated when you perform this by endoscopy. So you have a beautiful vision, magnified vision. It's a very stable vision if you're performing this robotically, but otherwise your good assistant can give you that vision. So this is one of the other very important advantages which I see when you perform the surgery with minimally invasive technique. Other place where I have found some advantage is the neck dissection. And this is one of the cases where the patient had, that's a margin mandibular now, I just ran the video a little faster. So this was a patient with scalp cancer with a parotid and neck node metastasis. So intraparotid lymph node metastasis. This is the sternomastoid muscle, omoid tendon, which is seen here. Here we are performing an R&D. Now, see, this entire surgery, this patient has to go for radiation after this because there's an extensive metastasis. So, by performing this surgery robotically, my question was, can we reduce the time to adjuvant therapy? So there's something which I was looking at, and after about 45 cases or so, when for whom we have performed robotic neck dissection, about 25 of them needed radiation, and we could start the radiation in 10 days' time for many of these patients. So this is the level 1A. You can see the anterior belly of digastric over there. Level 1B, we are saving the marginal mandibular nerve here. Facial vessels, that's marginal again, and facial vessels. Mylohyoid and the submandibular duct. Hypoglossal nerve. So the visibility of these structures, that's a lingual nerve. The magnification and the stable view is something which you cannot get in any other format other than robo when it comes to head and neck surgery. This is the facial artery, posterior belly of digastric. The external jugular vein here, that's the formation of it. And the sternomastoid muscle being cut at the top. This is the spinal axillary nerve, posterior part in the level 5. That is the, again, spinal axillary coming down from the canal. This is the IJV, that's completely dissected. IJV below. So in this case, we are performing radical, so we are type 2 MRND, sorry. So that is the IJV upper end being ligated. So after this portion is of parotid, but I think, in this case it was parotid metastasis, so we had to do a parotidectomy as well. You can see the marginal there, the lower trunk and upper trunk is visualized over there. So that's the upper trunk. You can see the buccal branches as well. So this is the dissected facial nerve. Now, this patient, this is the patient. So this is the scar at the end of it, and we could, in fact, this is one of the patients where we could immediately radiate him within 10 days. We started his radiotherapy, and he went on to complete it, and this is about, I think, a year after the radiation. I'm not going to present TORS because I don't think it's a part of it, but in conclusion, can it improve outcomes? For us surgeons, it is the question of magnification, that stable 3D vision, the wider vision that endoscope gives us, and better control on vision are the most important things. Apart from that, the tissue differentiation in the use of fluorescence is also very important. Other things which are there, which I can think of, are the tissue and access trauma, which can be there in some of these surgeries, not all, and recovery time in the form of going for adjuvant therapy, because neck incisions are not very painful. So it's not about pain, it's about the recovery and the adjuvant treatment, which could have some advantages when we give it early. And of course, lack of scar, which I always forget to mention. When it comes to another point about conclusion is here that, the robotic surgical robots are still young. We are still in the second generation. So as the things evolve and newer things come up, I think things may dramatically change in the way we are performing things. So lastly, I would like to invite you all for this NatCon IASO. Sir is the chairman of the group, which is, we are conducting it in Bangalore. I would like all of you to register and come for this. There's a NatCon IASO 2024, which will be in Bangalore in September. Also, I would like to invite you for this online program on 28th, which will be live on Lab Guru. This is on rectum, CA rectum. So I'm skipping from head and neck to rectum. Thank you very much.
I will invite the audience to interact, because he is not talking about the feasibility, he is talking about going to the next level, generation. Feasibility, yes.
So normally the dictum is the port has to be included in the radiation field.
Yes, sir.
So now should we have to include this axillary port site, because port site recurrences are very common.
So, what we are doing is for neck dissection, we are placing ports quite close, just below the clavicle, just below, about 1.5 centimeters below the clavicle, for neck dissection for oral cancers. And this was the main concern. So, we are radiating that, including in the radiation. My radiation oncologist is including that part in the radiation.
I have one quick comment and a question. Unfortunately, thank you for an excellent presentation, especially the excellent demonstration of a neck dissection robotic.
Thank you.
Unfortunately, we have to accept that in robotic head and neck surgery, the promise which we had about a decade ago has not really lived up to that promise. Unlike in other areas like the abdomen and prostate and all that, where robotic surgery has been a game changer, I don't think that it has really made that great a difference, because I would say a vast majority of head and neck surgeons are still not doing robotic surgery.
Agreed.
Do you have any idea as to why this is so? And is there any particular subset of robotic head and neck surgery which could potentially be a game changer in the future?
See, what I see is, I have trained for thyroid a lot of surgeons, and that has been picked up very easily. Like, in fact, in Chennai, in Omandore Hospital, they have done more than 40 surgeries already, thyroidectomies. So I think thyroid is quite promising, but neck dissection, I think by far people are finding it difficult to find the ideal candidate to go for it. That's one, because most of the cases come advanced. So where we can use neck dissection is in very selected, maybe 10 to 20% of the patients. So that is a challenge. And neck dissection robotically is challenging, because even for my team to copy it is a challenge. So whenever they call me many times, otherwise they are performing thyroids very commonly. They don't need me.
Yeah, thank you.
Sir is calling.
Dr. Anil,
Your comments.
I want your comments on this, because it's not a question of feasibility, I'm repeatedly telling. It's a question of, he's trying to say how well it can take to the next level. That's where the problem is.
I'll respond to Umanath and indirectly probably answer Sandeep. Sandeep, great presentation.
Thank you, sir.
Umanath, the reason why it's caught on in prostate and various other things, the benefit is tangible and very significant. In all our surgeries, the only real benefit is cosmetic. And the cosmetic benefit has not been validated over time. We all do thyroids open. 90% of our patients are satisfied. The West drove robot for a totally different disease, HPV. We don't see that disease. And with Orator 1 and Orator 2, there's no compelling evidence. So to me, it will take time to come.
Anyone else would like to comment on that? If not, thank you, Sandeep.
Thank you, sir.
It was a good presentation.
Thank you.